Can I stand up? Okay. So, first of all, thank you very much for providing this opportunity to show a little bit of our work. And we have structured the presentation in two parts. First, I will talk a little bit about the lobbying part. So I think since we're in Brussels and since we are leaders in the space, I think it's very important to understand the magnitude of the issue we are dealing with and some of the numbers. And so I'm going to start top down and looking at the issue in surgery. And as the second part, as mentioned, we will have after this an opportunity to drill in really in the use cases. What are we doing today? What can we do today? And we are, as a company, 10 years old, and so we are in the space for a long period of time. It's incredibly hard to stay alive and to grow and develop. And we are very fortunate to work with groups like Reliance, who are long-term supporters of Caresyntax and other digital solutions. And we are centered and only focused on surgery. So, why is surgery so important? Surgery is very important on the one hand because it's saving lives and because it is one of modern medicine's biggest success stories, I would say. So we started, as we saw in the prior presentation, which was excellent, that it was started in an operating theater in the universities, and there were hundreds of thousands of surgeries conducted every year. And now we are talking about the magnitude of 500 million surgeries per year, major interventions, and about, 500 million surgeries per year, and about 2 billion interventions globally. So it's a very big number in terms of quantity. And the activity and the place, the operating room, is statistically spoken the second most dangerous place in the world to be in after the battlefield. So if you're going into the operating room, you have a statistical chance of not coming out alive, which is 0.5%. Obviously, a lot of people that are going in have a major health issues that need that type of therapy. But there's also a lot of complications, and there's above 15% near misses that we can see in the data. And the question is always in this point, who is responsible for this? Is it Vicente? Is it the surgeon? Is it somebody that's running the hospital? And I always say, well, it's not, because there is just no assistant. So there is no one that is supporting the surgeon and the surgical team. There's no technology really that is supporting end-to-end the process. And that is what is driving this, because in other industries, let's say in commercial airlines or in the commercial aircraft industry, we are transporting as humanity 2 billion passengers per year. So it's a similar number to surgery. And there's almost no problems. And it's, if you think about it, flying through the air is kind of a miracle. Saving lives is also a miracle. But the difference is there's a co-pilot, there's processes, there's a lot of transparency. Nothing that happens in a cockpit is unrecorded. And if there's something that is not according to the plan, even now if actually the pilot touches the steering wheel, they have to say why. And that makes sense because lives are at stake, and that is the same in the operating room. But as we heard beforehand, the systems are not there. And the problem is actually financial, and the problem is in the system. So if we look at why innovation in healthcare is not adopted, it's because actually two reasons. One is healthcare is not a market, except in the United States, where actually most of the innovation is then adopted and driven. It is basically artificially, the prices for healthcare are artificially low because of the government mandating that. And there's also the same price for the best surgery or the worst surgery, at least in many countries. Doesn't matter the service level. So that it's not a real market. And the second point is it's driven by reimbursement codes. So reimbursement codes usually don't have digital solutions in them right now, so there's no reimbursement improvement or no financial incentives to adopt this type of solution. So those are the challenges that we're facing as innovators, and all of you are facing as well, to adopt innovation. And that's why today in healthcare, even though we have all the technologies to make something like surgery extremely safe, this is not a tech problem. It's an adoption problem, it's a money problem. So yeah, those are some of the statistics. I think what is interesting from a lobbying perspective for all of us and you is we're spending 1 trillion euros per year on surgery in the EU and UK, so combined. And so it's the second largest spend after pharmaceuticals. And the spend is going up dramatically, and the cost of risks are also going up dramatically. And there is a system in, now not anymore the EU, but in the UK, which is even not insurable anymore. So they had to nationalize the insurance of surgery, and now they have waiting lists because the hospitals cannot afford to pay for the insurance. So it's a fundamentally massive issue. And it's also a major emitter of greenhouse emissions. So we don't know exactly, but anesthesia gases is one of the most toxic gases in the world. So every surgery that has to be redone or that takes longer or things like that lands in the intensive care unit is creating this type of issues. Huge waste. So the statistics, you can turn them and twist them in whatever way you want. It is a massive problem, and we need to address it, because otherwise the cost will just go up and continue to go up, and we cannot afford it. And we will have the access problem in surgery. We already have it today. In many countries in the UK, there's 5-6 million people waiting for elective surgery, oftentimes cancer or things that are actually need to be treated. And I know in Germany or in many countries it's the same. It's still hidden, but we will have it. There's staffing shortages, we discussed it earlier. So we need to address it. So how can we do this? We are, as I said, since 10 years in the market, and we're taking really an ecosystem approach here. We don't think a single company or entity can solve this issue. It's far too big. But we can work together and create incremental change and incremental improvement. And the first horizon we had to, I guess, tackle, and we're still tackling, is collecting the data. So right now in our systems, we have about 10 million surgical records as metadata, and we have tens of thousands of complete, as we call them, high-fidelity surgical records, which comprise pre-surgical data, so diagnostic anamnesis and so on, intrasurgical videos and data from devices, so from the operating room, and post-surgical, sometimes medical malpractice claims data and also outcome data. And we're working together with medical device companies, with insurance companies, and we also have and had to raise a lot of money to get here, so we raised over $250 million so far to basically be in this position. And this is how the platform looks like. As we mentioned, later on we will have more concrete use cases of how it is playing out in practice in private and public teaching hospitals. But the concept is quite simple. We are integrating back-end data from EMR, staffing, and supply chain systems. So we're collecting through HL7, FHIR, and DICOM the data that is available from before the surgery. And we're doing this through automatic kind of interfacing. We map the data beforehand. Then we are putting high-powered edge compute and IoT in the operating room to connect the medical devices that are present and record videos and make sure that there's workflow software in place. That is where Caresyntax is the leading system. So we have installations of software in about 1,500 operating rooms in Europe and the United States. And that is a very important tool to support the surgeon and the surgical team, as we saw beforehand, but also collect data. And then we're starting to collect outcome data, which is not easy to get to, but we're working on that. And then we have the high fidelity surgical record, and then we can do a lot of things with that. We can review, obviously, cases, risks. We can improve reimbursement. We can make it performance-based. We can reduce liability premiums by having such a system installed. And we're experimenting a lot with value-based care models, which actually, in the first moment, just reward collection of this data. So in the US, for example, there's bipartisan legislation called MACRA-MIPS, and it's incentivizing Medicare, Medicaid hospitals to collect data automatically, so not only in written format. And if you do it, you're getting 3 to 5% more per case, which is immediately bottom line relevant, so it makes you more profitable to collect the data. And then we are developing tools to improve patient safety, operational efficiency, and profitability. We estimate that we need tens of thousands of these applications and tools. So again, we cannot develop them ourselves. We need partners and medical device companies, clinical specialists, and others to work on the data and work on the platform. But we want to provide this as an open, kind of ecosystem approach. Obviously, we need to make money and monetize that as well, but we believe in an open approach. We're competing a lot with medical device companies that are trying to create their own walled garden. So let's say Intuitive or Stryker have very powerful sales force and also very good digital tools, but they are creating systems that are not accessible and interoperable, and that is not in the interest of the patient, the payer, and the hospital. But they have more marketing power, and oftentimes, obviously, they can provide this type of solution almost free of charge. But we believe in an open approach, and the interfaces to our system cost nothing. So as a hospital, if you want access to our data, after obviously buying the solution, there's no extra cost to interface with a different system to read and write the data and so on, because that is needed to achieve our objective. And we have found a lot of ways how to create this data collection, which is very sensitive because we're talking about employee data, patient data, and so on, in an anonymized way. So we are de-identifying the data at the source. We're bringing this edge compute in the operating room, blurring out however much you want to blur out. In Germany, you have to blur out everything. In some countries, you just have to blur out the faces. In other countries, like France, you have to be able to identify the face of the president so that you can blur out everything if the president is in the operating room in a few hospitals. But so there's possibilities to do that, and we're doing that. And we're making it basically quite easy to implement, also from a liability perspective, because we are storing all this very rich data outside of the EMR. And depending on the country, there's different ways how to do that, so it's non-discoverable in legal proceedings, which is also very important because you don't want to capture data and then get sued. So we're storing it in, for example, in the US, it's called a patient safety organization, where you kind of donate the data but can still use it and monetize it. In Germany, we're doing it as research data, which is also not discoverable. So there's ways how to do this, which is safe from a risk perspective. And we're working with the leading liability insurance. So basically, there are a lot of incentives to deploy this type of solution from that perspective as well. And there's some monetary incentives and things that we're putting in place. But in general, what can we do for you today? We can make your surgical operations very efficient. So it's a factory-like efficiency throughput management tool. There's scheduling elements, dynamic scheduling, predictive scheduling. I can take the data and tell you which surgeon is turning up on time, and some maybe not, and they get a reminder beforehand, or the teams who are prepared in which way. Sorry, and most surgeons turn up on time. The teams who what is their kind of training level? Have they worked together beforehand? Do they maybe need more time to prepare the surgery? Do we have a broken down preference card that we call kind of step-by-step or turn-by-turn guidance for the teams? Because as you all know, staffing is the main problem, and actually the nursing staff is the main problem. So getting them ramped up quicker is a solution we developed together with Intel and Google in the US, which we're also launching in Europe. And so there's a lot of KPIs that we can improve. They always depend on this hospital that you're running. So, sometimes people ask me, okay, what can you do? And it's a lot of things we can do, but first of all, I need to understand what is your activity level, what are your problems, and then I can benchmark them against the 10 million cases we have, kind of model out your hospital virtually in a way, and then we can look at the variations in different KPIs and clinical specialties and so on, and then work on identifying improvement potentials and also work on implementing tools that help in the day-to-day. And yeah, we can talk more about it later on, but I guess for now, thank you very much for this opportunity, and I hope we can engage in changing and transforming surgery and making it safer and smarter.